Previously on the Dr. Meade Show.
We have a special edition today on hip surgery. I have an expert panel assembled today to answer a lot of questions individually. Let me just quickly introduce the panel. Dr. Pete Sharkey, Professor of Orthopedic Surgery. Pete's an officer in the American Association of Hip and Knee Surgeons. Leo Scarpino, perhaps the most experienced surgeon on our panel today. Mike Bush and I go back to our trauma days at Lehigh Valley. Mike, too, has done thousands and thousands of joint replacements and trained at Hospital for Joint Disease in New York. Kevin Ambari, stellar surgeon, trained at Harvard, University of Pennsylvania, Charlie Ang's fellowship, and actually has an MBA from Wharton. Let me tell you a little bit about hip replacement surgery. It is probably one of the most successful procedures in all of surgery, not only orthopedics. It decreases your pain, improves your function, improves your quality of life.
The pain and disability associated with hip arthritis is absolutely terrible. It's considered one of the most painful, disabling conditions you can have.
The age itself is not a contraindication to doing a hip replacement. I've done recently some 91 and 92-year-old patients who had hip replacements.
I think the issue with metal on metal, and some of it is actually specific to how you position the implants. We've learned a lot more about how certain ways that you position the cup, for example, lead to more wear on a particular part of the metal on metal articulation.
You're not really losing the prosthesis. We're talking about microscopic amounts. You know, they measure in billionths of particles. So that prosthesis is as strong as it ever was, but it's the effect of these micro particles and the body reacting to them.
Hip replacement is, I'm not going to say it's one of the most, it is the most miraculous operation that doctors do today. You can take somebody who's essentially in a wheelchair and restore them to a very high quality of life.
I want to just give the correct impression here that the thousands and thousands of people who are getting the surgery on a yearly basis are doing just fine.
3 to 5 years ago, Zimmer was pushing their mini 2-incision approach. There was a tiny little incision in front and a tiny little incision in back, and everybody was rushing to it. And then as it got out into the community, they found out that there were a lot of complications associated with it. It's a lot more than was seen in the studies that came out and the people that were proposing it.
I've done the posterior approach for 30 years and had excellent results. It's still the most widely used procedure in the world, and the results are excellent.
Probably the biggest breakthrough is a concept called cross-linked polyethylene. And what we found about, late 1990s, early 2000, that if you take the polyethylene, and that's the plastic in the hip joint, and you take that polyethylene, warm it up, and then expose it to radiation, it cross-links the long polymeric molecules and essentially reduces the wear to zero.
The hip can be approached from the side, from the front, from the back. And really, what we're out there trying to do is lower the complication rate.
With the anterior hip approach, it's not something that was just created yesterday, though. This has been something that was studied at length for years, and I think even with the new push in the last few years, it's not something that just came out in the last month or year. I've actually watched it and waited to see if it was going to balloon or whether it was going to go by the wayside, and it looks more the former than the latter. So that's why I decided to go on. What do you think?
I'm going to make an executive decision and say there's going to be a part 3 to this show to address some of those issues. Of hip surgery, the most successful show we've had to date and the most controversial. We're talking about what if it was all a lie. We're going to address many of those issues in hip surgery where there is misinformation. We have a great panel, Dr. Sharkey, Dr. Leo Scarpino, Dr. Mike Bush, Dr. Kevin Ambari, some of the best training in the country. These guys perform close to 4,000 joint replacements a year. We've answered a bunch of questions in part 1 and part 2 on metal hips, anterior approaches, rehab, activity after hip surgery. What's the next burning question? Yes, sir.
Good questions. Ceramic is not really an option with the current modern hip resurfacings. I will say though that the one that is most typically used is one that was very well researched, and I would have no problem implanting it in my patients, and I have in the past, despite all that we've learned about metal on metal. I don't hardly ever do any metal on metal hip replacements anymore, but if somebody wanted a hip resurfacing, like I said, it would be a metal on metal hip, and I would feel very comfortable with that. And it makes sense in the younger active male population. And that's been studied in excruciating detail by the originator of this from Europe. And actually it's been shown to be a really good prosthesis. In terms of a ceramic in a hip replacement, like it's been said before, everything in life has an advantage and disadvantage. The point of ceramic is that in the laboratory, when you put a ceramic ball on a plastic socket and you test it with millions of cycles, it seems to wear the plastic out even less than a metal ball does. But the main advantage really right now to hip replacements in the last 10 years is that the plastic itself is much better quality, like Dr. Sharkey said in the last show. Ceramic may be, however, even better than a metal ball in reducing that wear rate even more. The main disadvantage is a 1 in 10 to 20,000 chance of the ceramic ball breaking. But what I tell my patients is bone can break, metal can break, and so can ceramic. But it's extremely unlikely. You can take a ceramic ball and literally throw it across on the wall and it won't break. But that's something that I do tell my patients for the sake of completeness. It does make sense in the younger patient. Does that answer most of the points?
It does. Has anyone ever heard of a squeaking hip?
Right, so that, the squeaking is a particular design from a particular implant company that is a ceramic ball on a ceramic socket. What I was talking about is a ceramic ball on a plastic socket, and there actually there is a point to putting a ceramic ball on a ceramic socket because then the wear rate is basically zero. But you do have that occasional issue with squeaking, and I've witnessed it in some patients who have come for second opinions, and it's actually very intriguing. It demonstrates what the body can do with some of the things that we do to it, you know. But I think actually Dr. Sharkey probably has a little bit of insight on that.
Pass the microphone.
Yeah.
I think Dr. Sharkey's done some research on the. Can you have singing hips for Christmas?
Well, there are certain patients that do learn how to make the hip entertaining. In fact, I'll tell you an anecdotal story. I had this one patient come in, and I don't if you haven't heard a squeaking hip before, it is unbelievable. It sounds like a rusty gate hinge opening and closing every step, right? So I had this fellow come in, and he was squeaking as bad as anybody had ever heard squeak before. So I said, well, you must want to get this fixed because it's easy to fix. Just convert him over to a plastic bearing. He goes, are you kidding? He goes, this thing is great. And I go, what do you mean? He goes, I win more money playing golf with this thing. He said, whenever I'm playing golf and somebody's ready to putt, I just move a little bit and that thing starts squeaking. He goes, hey, it's not my fault, it's the hip, you know? And it was one of these guys, just good-natured guy, and he said, look, it doesn't hurt, and they don't hurt. The squeaking hips don't hurt. But the people that I found that really don't like them are women. Women don't want to walk into a party and sound like a rusty gate going into the party. The men tolerate them a little better.
Great. Athletic gentleman in the back. So 85-year-old patient with a hip replacement wants to know if it was a good one or a bad one. Is it on the recall list? Mike, where would you look that up?
Well, I think you have to go to an orthopedic surgeon and let him see exactly what kind of hip was implanted, and then he can tell you whether or not it was recalled. But it's very specific as to which ones. Some were not actually recalled. They're just not recommended to be put in anymore. So I think that's the best place to start is with an orthopedic surgeon.
Great. Question in the back. Dr. Scarpino, how do you help a patient walk through that decision tree and meet the goals which are different in every single patient?
Well, first of all, you don't need a hip replacement or any procedure unless you're having pain. If you have restriction of motion, stiffness and the pain is not terrible and it's not debilitating, there are conservative measures that you can do to treat the hip. That would include anti-inflammatory medications, physical therapy, intra-articular hip injections of cortisone. If the symptoms become debilitating, then the options would be, a resurfacing would be an option, which I don't perform, but a hip replacement also would be indicated. How aggressive a skier are you? Aggressive, okay. I allow my post-op patients to ski. I tell them to watch out for the bumps, you know, and I do this with tongue in cheek. I recommend that they don't jog, you know, 5 miles a day. I know Pete has a patient who does that. You know, I worry that that's going to cause increased wear, increased rate of loosening. But from a standpoint of hip replacement, the only restriction I recommend is that they don't jog. Other than that, I let them do anything they want. From a skiing standpoint, I tell them to watch the bumps.
Back corner. So that's a great question. How often do we have to fine-tune the hip? And I'll bracket that question and say, what is the reoperation rate in the first year after a primary hip replacement in a healthy person? Kevin?
I don't know if I can quote you an exact rate, but I think unlike LASIK, when you're trying to get to 20/20 vision and maybe you get to 20/40 and you're not there yet, this is not the same thing. I mean, you're taking out the arthritic joint, you're putting in a new joint that should be good right away. The reasons to reoperate can often be, actually it's not often, it's very rare, but the reasons to operate could include things like infection of the skin incision, say if the hip dislocates or breaks, especially people maybe with weaker bone. But overall, I would say the rate is very low.
Yes. Well, that's a great question, because when I used to do hip replacement surgery and knee replacement surgery, what I found was my hip patients felt that their hip was normal after a while. It felt like their own. Whereas the old knee replacements, it was a great operation, their pain went away, but the majority of them felt like it was an artificial knee. Our newer technologies is shifting that, but I'll ask Dr. Sharkey to address that.
That might be the best question today, because even doctors don't agree on this. And there was recently a survey, organization, American Association of Hip and Knee Surgeons, 1,500 members. Everybody in the organization does at least 100 total joint replacements a year. We sent a survey out to the entire membership and gave them a list of activities, everything from snow skiing to riding a bicycle to playing singles tennis to playing golf. You cannot believe how much variability there was in what doctors told their patients they could and couldn't do after surgery. It was unbelievable. I mean, there were some doctors who recommended extremely sedentary lifestyles, and there were some doctors who recommended that you can do whatever you want to do. So basically, what I tell patients is I say, just do what you want to do. I figure people are going to do it anyways, like you, you know? And so I just say, do what you want to do, and there's no proof that there is any right answer.
Yes, sir. So we have a great question on a complication of a hip procedure, the most successful procedure possibly in all of surgery, but they don't all do perfect. Here we have a problem. It's loose, 2 revisions. What are our options? A very specific question. And on the right, we have one of our audience complaining that we didn't answer enough general questions. So after this, we will answer a specific and a general question. Stay with us. Folks, we're back, and we have a very specific question here on a difficult problem, on a second revision, on a young, active, athletic male, possibly with some bone loss. What are the options for bone loss? Dr. Ambari.
The good news is that we have come up with new technologies to combat that problem. I mean, a second-time revision, there's probably going to be some significant degree of bone loss potentially. The best advice is to make sure that you're with a surgeon who deals with that problem on a regular basis. And in the past, we used to rely on what you call allograft, which is basically bone from the tissue bank. But now there are actually very good technologies where we are different augments made of a specific type of metal that has similar properties to bone that can actually be used, and then you take what it could be a large defect and you make it a much more manageable defect. So that's probably one of the good things that have happened to hip revision surgery in the last few years.
Does that answer your question?
Well, the new material that I was referring to is actually just a piece of metal made of tantalum. But bone graft has been used for a long time with good results. It's questionable whether it really, whether there's more life in that bone or not. It basically just used initially as just a structural strut, so you can implant your new cup. But we've used for people, for example, with tumors and things like that. We've used large pieces of bone from cadavers to substitute for that, and it seems to work just fine.
The material that Dr. Ambari is describing, this tantalum, it has a, if you look at it under a microscope, it looks like real bone. And your body thinks it's real bone, and it can grow in there. And as opposed to allograft, there's no risk of rejection. There's no incorporation that has to go on. And so it's really been a breakthrough, just as he said, it's a breakthrough metal. And it's probably, if you've had 2 revisions or you're going on your 2nd revision, you're probably a good candidate to get that kind of material put in there.
Great. We had a general, where's my nice patient with the general question? Was that? How does the patient decide? How does the patient decide between which approach should they have on their hip? Dr. Bush.
I think that's really a surgical decision that you have to discuss with the surgeon, go over the benefits of both, and come to some conclusion. If you try and force a surgeon that's used to doing an anterior approach to do a posterior approach, that's not good. And vice versa, if he's used to doing a posterior approach, force him to do an anterior approach that he's not as comfortable with, I don't think that's a good idea. So it's really your rapport with the surgeon and how you feel about it. They both have long histories, and both can be done well in the proper hands.
Surgeons will be passionate about the approach. They'll have preferences. They like it for various reasons. But there's not one single good scientific study out there showing that any one particular approach is superior to another. So really, you should interview the doctor. If you like the doctor, you feel it's a doctor you can work with, who cares what approach he uses? They all work. You should be comfortable with your doctor. That's the most important thing. You'll get a good result no matter which one of the approaches are done.
So we don't discriminate against redheaded females, so we're going to go right to the back. It's a great question. In the knee, we do a lot of bilateral knee replacements. How often does that happen in the hip? And what's our success rate in hitting equal leg lengths? Dr. Sharkey.
Well, first of all, I bet you're really glad you brought her today, aren't you? But anyways, bilateral joint replacement is fairly frequently done today. We do it much more often than we used to for a lot of reasons. And if you go to somebody who's experienced and you're healthy, it's safe. It's considered safe. As far as getting the leg lengths right, it might be easier, at least I believe it's easier, to get the leg lengths right when you're doing them at exactly the same time, because you've just finished up the one side. You can check the leg lengths at the end of the case before you drape and do the other side. And you also have a very good feel of what that first hip was like, what the soft tissues were like, what the bone structure was like, what parts you used, how the parts fit. And I think it's really easier to get the leg lengths right when you do them both at the same time, just because you have much more familiarity with it. If you did it, 6 months ago and then you're back, you don't remember what you did at that first operation.
Dr. Sharkey, is it a bad indication if you go into an orthopedic surgeon's office and he has an investment in a bunch of heel lifts in the waiting room?
Yeah, I would watch out for anybody who carries heel lifts or wheelchairs.
Wheelchairs. Next question. Yes, ma'am. Great question. Probably our last question here today, so I'm going to give it to our senior member of the staff, Dr. Scarpino. First question, if you buy a Chevy, do you buy it again because you liked it? And number two, is there a female hip like there's a female knee?
Well, first of all, there is no female hip. When we do the surgery, we're like an auto parts store. We have multiple trials that we will actually size the component to your bone specifically. Once we have the trials in, we're happy with the offset and how they work and how the stability is, then we go to the shelf, open the sterile prosthesis and put it in. So we really do not have a specific female total hip. The other question, as far as using, are you going back to the same surgeon? Then he'll probably use the same components. Do you have, what do you have in now? Titanium. Then most likely he'll use the same components. If he uses different components or different company, the components will still be compatible.
Dr. Scarpino, I don't want to stop you. Thank you. That was, we're out of time. That was the quickest show, the quickest multiple shows we've done. What a panel, Dr. Pete Sharkey, Dr. Leo Scarpino, Dr. Mike Bush, and on drums, Dr. Kevin Bari. Great. Thanks for joining us. There is no part 4. Join us next time.